Welcome back to our monthly geriatric echo. Excited to see you. And oh, I see Jeff has his whole family there on his Zoom screen, and just good to see you again, Jeff. And I see, yeah, hold on a second here. All right, so let's get started. We have a great speaker today. We're going to talk about reducing falls, and we have a physical therapist with us today. So let's see, next slide. Okay, so this is our Project Echo, free CMEs, distance technology from the comfort of your living room or office, online learning, interdisciplinary expertise. We have a nice panel here for you as usual, and of course, a community of learning. Oh, and Joseph Kahn, it's good to see you again. It's been a while. Great. Okay, next slide. Okay, and of course, feel free to share your cases. Our team is willing and happy to share our collective wisdom with you. We love challenging cases. Next slide. And of course, just a reminder, we keep everything HIPAA compliant. Don't share patient identifying information, but we also want to create a safe learning environment for here as well. Next slide. And for CME credits, there is, after you register and at the conclusion towards the end of this hour, there will be a link put on the chat box for you to click on to do the evaluation right away. You can get credits with that. I think you guys know Zoom already, but just reminding you that enter your name and others joining today's session with you in the chat box, and that is our way of taking attendance. So see, you can follow after Dr. Khan. He actually did that for us. Thank you for being a great role model. Okay, our hub team, I'm the course director. We have Sarah Tompkison. I don't know if she has joined us yet. She may be a little bit delayed. We have Lucas. Oh, actually, you know what? This slide is a little bit off. So we have Chad Kawakami with pharmacy joining us again after serving with us. He was deployed for many, many months, and it's great to have him back. And we have Mary Gotham back too. Has been away for a little while. So she's our public health nurse, retired public health nurse. So thank you so much for joining us. Okay, I'm introducing the speaker now is Dr. Kenton Kong. He is a doctor of physical therapy from Washington University in St. Louis. He's actually from here and he's come back home. So his areas of expertise include outpatient orthopedics, geriatrics, pediatrics, neurological, cardiovascular, vestibular, and youth sports. He is a practitioner of the movement system impairment model, and he utilizes his training to identify and improve deficits and imbalances to address movement impairments, contributing to decreased functionality and quality of life. So we look forward to hearing him and everything he has to share. So thank you very much. I'm going to give you the stage.
Awesome. Thank you very much, Dr. Nguyen. Am I able to share screen from here? Here we are. Let me just bring this up. Wonderful. All right. So thank you. My name is Dr. Kenton Kong. I'm a Washington University in St. Louis DPT graduate, but born and raised here from Mililani. So it's always nice to be able to give back to my community where I'm from. All right, today we're going to be talking about fall risk in older adults. I wanted to provide kind of a mini scientific literature review so that we can make the most informed decisions as healthcare practitioners and be able to best educate our patients to keep them safe as well. Here are some learning objectives. If you guys have any questions, any comments, please feel free to jump in the chat box or to just jump in during discussion. Enjoy, engage. I'm very excited to learn together. So thank you for the ECHO team for providing this safe space of communication for us. The outpatient setting, we don't always get communication with other areas of expertise. So thank you very much. Okay, so starting with the definition of fall. So according to the World Health Organization, fall is defined as an event which results in a person coming to rest inadvertently on the ground or floor or other lower level. It also goes on to say that in all regions of the world, death rates are highest among adults over the age of 60 years. I did not need to cite World Health Organization to inform healthcare practitioners and even non-healthcare practitioners that falling at an older age can result in severe injury or risk of death. But I want to give insight into some major resources, better understanding for us as healthcare practitioners and for what our patients or patient caregivers may see if they're doing their own research. So on that note, this is a CDC website for older adult fall prevention. Personally, I actually like this site better. It had more organized information. It had information data on fall rates, mortality rate, annual associated costs, information gathered by state. The best thing I liked about this site was that it provided works cited information at the bottom of the page for each link. So if you guys need a resource to send your patient's way or patient's caregivers, highly recommend this. That has literature cited at the bottom of each page. All right, so according to the CDC in the United States, about 28% of older adult Americans fall each year, about 37% reporting injury requiring medical attention. In the beautiful state of Hawaii, we sit at about 20% of older adult falls annually, which is lower than the national average. The Center of Disease Control found these informations from the Behavioral Risk Factor Surveillance System from 2012 to 2018. And so since the world, I know, doesn't revolve only around outpatient therapies, I wanted to provide some information on the inpatient side of things as well. And so this 2013 article from the National Database of Nursing Quality Indicators pulled information from 1,500 hospitals across the US from 2006 2008 and estimates 3.53 falls per 1,000 patient days and about 0.91 falls per 1,000 patient days. Fortunately, only a fourth falls resulted in injuries, right? Most of which being classified as minor. In this study, they defined it as dressing, ice, topical medication, limb elevation, or just cleaning a wound. And they found that the unit with the greatest amount of falls were medical units, med-surg, and surgical units. So if you work in these areas or you know anyone that works in these areas, just be aware, educate yourselves, educate others that according to previous studies, your unit may experience 3 to 4 falls every few months. The mortality rate, according to CDC and the web-based injury statistics query and reporting system, or WSCARS, they estimate 64 deaths per 1,000 older adults. Here in Hawaii, sit at about 53 deaths per 100,000 older adults due to falls. So similar to fall rates, Hawaii is still below the national average, but the overall age-adjusted fall death rate continues to increase. In fact, it increased by about 30% from 2009 to 2018. Oh, I'm sorry, age for older adult defined. In different studies, it's defined differently, most of which is 65 years and older. There are some studies I found that define it as 60 years and older. But I believe CDC is 65 years and older is what they define older adult as. What was that? Yes, the 30% increase from 2009 to 2018. 30%. I'm freaking out when gas prices are going up by 10% and older adult fall mortality has increased by 30 from 2009 to 2018. So it's an alarming rate, but we can positively influence the statistics through conservative multifactorial approach. This 2015 study conducted in Malaysia gathered data from older adults reporting to the ED after a fall. So they collected socio-demographics, fall characteristics, independence levels with ADLs upon admission. During the follow-ups, they observed that about half all subjects had deceased within 5 years after that initial ED visit, and about 80% of subjects had passed away within 10 years following the initial ED visit due to a fall. Statistical analysis showed significant association between mortality and older age. In this study, older age was 75 years and older. A significant association between mortality and hospitalization admission or admission to the observe ward, and an initial Barthold Index score of 18 or less. For those of you who are not familiar with the Barthold Index, it is a 10-item scale that assesses independence with ADLs, so bowel and bladder, grooming, toilet use, feeding, transfers, mobility, dressing, stairs, and bathing, for a total score of 20. Basically, a 0 means you are dependent, 1 meaning you need assistance, and 2, you are independent. So according to this study, they found that if you are 75 years and older and need you need assistance with 2 or more ADLs, you're an ED visit for falling and a hospital admission away from approximately a 10-year life expectancy. You know, about 50% chance you make it half a decade more. So falls are very serious. According to the CDC, the US spends millions and billions of dollars annually related to fall-related costs. The state of Hawaii spent about $172 million in 2014. And this quote coming straight from the CDC website: direct costs do not account for the long-term effects of these injuries, such as disability, dependence on others, lost time from work and household duties, and reduced quality of life. I'd like to repeat, direct costs do not account for the long-term effects of these injuries. I just want to highlight as we went on today that these numbers represent people. And so this $50 billion spent on medical costs related to non-fatal fall injuries in 2014, that's $50 billion spent on people who fell and may have had long-lasting detrimental effects from these falls. So just some things to keep in mind as we go along. All right, so we know that falls are a problem, right? We know that they amount to millions and billions of dollars annually, right? That older adults are at higher risk of mortality after experiencing a severe fall. And that fall rates in older adults have increased by 30% from 2009 to 2018. All right, my next question is, where do you think most falls occur for older adults? I'll give you guys some multiple choice answers. Go ahead, throw them in the chat or speak up, whatever you guys think. You guys think most older adult falls occur while out shopping, while at home, while exercising, or medical setting, inpatient, outpatient, offices? Let's see, home, bathroom. Very good answers. Be at home. I love this community. So this 2017 study collected information on about 35,000 older adults, gathered from the annual National Health Interview Survey by the CDC from 1997 to 2010. And you are all correct. Yes, doesn't matter, indoor, outdoor, it was a significant amount they found. Older adult falls occur primarily at home. The most commonplace indoor falls were experienced for women were stairs. And then the second place, very closely, was in the bathroom or in the restroom. The most common indoor place for falls for men was in the bedroom, followed closely by the bathroom or restroom. So indoor for both genders, bathroom is a very common spot. The most common place for outdoor falls to occur for older adults was in the garden, the yard, or in the lawn. So if you have personal experience or know someone who may have had an incident while outside in their yard, you can let them know. There's studies that confirm that. So be careful out there. Okay. This graph coming from the same study shows in the light and dark blue colors the indoor and outdoor home falls for the male group and for the female group. And as you can see, majority of it is blue, showing that most falls do occur at home. except in the young adult male section where most falls occur in the outdoor park, recreation, sporting facility area. And this graph here from the same study showing the activities preceding these fall injuries, which they recorded. And so across all ages and genders, the most common preceding activity before a fall is walking, highlighted in these blue areas. Again, the only exception was the young adult male group who had vigorous activity preceding falls, possibly giving us insight as to why males have shorter life expectancy. Who knows? But also noteworthy here, these nice big chunks of red. These stairs were found to be the most common place for falls for women across all age groups. So just something to be mindful of. All right. So some fall risk factors that we should be aware of as healthcare practitioners. We know that as we age, fall risk increases. Sedentary lifestyle can lead to other problems such as deconditioning, muscular weakness, imbalance, additional comorbidities, reduced quality of life. Visual impairments and medication can also affect balance as well as deconditioning. Cognitive impairments add that extra layer of safe decision making in there. And gait speed. Gait speed in the PT world, sometimes we refer to as the sixth vital sign, as it definitely demonstrates fall risk as well. And let's not forget previous fall history. All right. Anytime you are assessing previous falls with elderly patients or anyone who may be a fall risk, I always ask them, have you fallen the past year? And I always go the extra step to ask them if they've had any near falls in the past year. Your patients, even if they haven't had a fall in the last year, if you ask them if they've had any near falls, the answer may not be the same. So it's definitely worth a few extra seconds to ask. Okay. This small cross-sectional cohort study from 2018 was examining gait speed and fall risk factors amongst community-dwelling older adults. They found that the average gait speed for these individuals was about 1 meter per second. About half of them were below average of that 1 meter per second. And the below average group was found strongly associated with a history of multiple previous falls. So here we can see both groups had individuals who suffered at least one fall in the past year, the above average and the below average gait speed groups. But it's significantly higher here for multiple falls in the group that was below the 1 meter per second. Yeah, it's all good information, but my PT brain is already thinking, what's causing this slow gait speed? Shuffling gait, additional comorbidities? Is there a thoracic kyphosis? Is it muscular weakness? So the gait speed itself does give us insight, but the PT brain in me is just jumping ahead, trying to figure out what would be contributing to those factors. This 2021 systematic review, utilizing 22 different studies on older adults who were recurrent fallers, basically you have findings that support the previously listed risk factors that we covered over there. They found that the domains associated with the highest increased risk for recurrent fallers were balance and mobility, medication, psychological, sensory, and neuromuscular. This 2021 systematic review pulled information from the National Vital Statistics System and Medical Expenditure Panel Survey from 1999 to 2017. And in that 18-year span, statistical analysis showed that age-adjusted mortality due to falls increased from 29 to 63 deaths per 100,000 people, which we already knew that mortality rate due to falls has been continually rising over time. Okay, but the main part of this systematic review is that it found that the number of persons receiving at least one fall risk increasing drug increased from 57% in 1999 to 94% in 2017. So the chances that your patient is taking at least one FRID is pretty high. It's almost guaranteed at this point. All right. They classified these fall risk increasing drugs based off of steady, stopping elderly accidents, deaths, and injuries. So according to that classification, they found about 94% in 2017. This graph here shows the percent of persons receiving at least one FRID from 1999 to 2017. Here we can see that opioids were the highest. After about 2015, it starts to decrease. Antidepressants and anticonvulsants were on the rise since 1999. Some of you may have noticed that the last line in my previous slide had mentioned that antihypertensives were the majority of FRID prescriptions, was at 71.2%. But the authors noted that they omitted the antihypertensives from this graph for readability. If we were to triple this graph here, then we would finally be able to see how antihypertensives compared to the other drug categories. 71.2%, vastly the majority of fall risk increasing drugs prescribed to patients. And here another graph from the same systematic review. The light blue line showing the percent of persons with at least one fall risk increasing drug, and the green line demonstrating deaths due to falls per 100,000 persons. And upon gross visual assessment, we can see that there is at least a correlation between the two, right? You can see how each one just steadily increases over time. Here I provided several links, some resources to assist with deprescribing fall risk increasing drugs. So the Beers criteria you may have heard of, developed by the American Geriatric Society. The first link is the 2012 medication list from the Beers criteria, and the 2019 updates in the second link. This was found via the American Pharmacists Association, continuing pharmacy education. On the bottom is STEADY, Stopping Elderly Accidents, Deaths, and Injuries, created by the CDC. It provides a screening questionnaire to assess if at risk for falls, steps to prevent falls, if not at risk, assessments to perform if deemed at risk, and instructions to providers to address the identified areas of deficits based off of those assessments. So does medication review work? All right. This 2020 randomized controlled trial was examining the effects of the medication. Oh, one second. Evaluation of blood pressure control versus blood pressure meds. Were more falls and hypertensives related to low blood pressure or high blood pressure? I did not examine low to high blood pressure or the effects of blood pressure control medications specifically. It was just found that 71.2% were antihypertensives themselves. That would be a little bit more literature review. I would have to look into specifically for hypo or hypertension falls. Where was that? Okay, this randomized controlled trial was studying the effects of medication review from STEADY on fall prevention. And so with these adults aged 65 years and older, they were given these STEADY screening questions. Have you fallen in the past year? Do you feel unsteady when standing or walking? Do you worry about falling? If patients answered yes to the previous questions, then they were screened positive. Therefore, their medication list was given a review by a pharmacist, and that medication review list, those revisions were sent to the primary care provider. Fall data was recorded for 12 months prior and post-intervention, and the study found no significant changes between control and intervention groups. So this graph shows the drug burden index scores pre and post intervention. The yellow line being the group that screened positive and received the medication list review. The green line being those who screened positive and received no medication list review. As you can see that this DBI score decreased for all groups post intervention. So the authors noted, obviously there may have been some biases, whether it was from the primary care providers inadvertently deprescribing drugs, or perhaps patients became more aware of polypharmacy after receiving those questionnaire questions from STEADY. This graph from the same randomized controlled trial shows here that pharmacists recommended medication switches primarily rather than ceasing certain medications, because in the real world, where we deal with real patients, we understand that sometimes benefits outweigh the risk of these medications and that these medications are being prescribed for a reason. Unfortunately, this little blurb here shows that about only 10% of providers actually planned to use these medication revisions or to change medications despite pharmacists' recommendations. Now, I'm going to tell anybody how to do their jobs, but I do believe a multidisciplinary approach to treat the whole patient means we all work together as a team. I do believe the model works better. We can draw from each other's areas of expertise. And this is what ECHO is for as well, is a team approach to learn and to utilize each other's specialties so that we can help others. Just some food for thought. This 2021 systematic review and meta-analysis examined the effects of deprescribing FRIDs on falls and fall-related outcomes. 2 of the studies utilized physicians, 3 of the studies utilized pharmacists to review the medication lists. And ultimately, the majority of the authors found that deprescribing FRIDs alone did not reduce fall rates or risk of falling in older adults in a 6 to 12-month follow-up period. It was also noted that successful discontinuation and adherence to deprescribing drugs were low in all studies. So not very high quality evidence supporting or refuting deprescription as a single intervention. So if deprescribing these fall risk increasing drugs alone aren't enough to decrease fall risks, what does the literature recommend? Right? This systematic review from 2021 examined 15 different fall prevention guidelines for older adults from all around the world. So this included American Geriatric Society, National Institute for Healthcare and Excellence, STEADY, Kaiser Permanente, British Geriatric Society, French Society of Geriatrics and Gerontology, et cetera, et cetera. And out of the 15 guidelines that were studied, the most commonly addressed areas were assessment tools and exercise interventions being included in 15 out of 15 guidelines, followed closely by multifactorial interventions, medication review, and environment modifications. Now, does anyone know what the term multifactorial interventions means? Go ahead, shout them out. Chat, shout them out. Any ideas? All right. Yeah, we just break it down. Multi meaning more than one, meaning that single interventions aren't recommended to magically fix fall risk in older adults. Absolutely. The downside to that is that they do use it as a broad term for treatment as defined in studies and even in guidelines, because worldwide, people understand that there's just not a single answer to this problem. This 2021 systematic review is examining fall risk interventions on community dwelling older adults. It did find that exercise as a single intervention was strongly associated with decreased number of falls and fall-related fractures, as well as basic fall risk assessments. However, multifactorial interventions were significantly associated with reduced fall frequency. So here's that term, multifactorial again, right? Here it was defined as exercise, assistive technology, environmental assessment and modifications, quality improvement strategies, basic fall risk assessment. So basically everything that we said on that last slide that was recommended, right? They just included all of it into one term there. Another systematic review examining fall risk interventions on preventing falls. I found that multifactorial interventions may improve fall rate, risk of a single fall, and recurrent falls. The authors did note that multifactorial interventions did not show as much benefit in reducing fall rates compared to usual care and fall prevention advice. But as I was reading this article, I was like, usual care, fall prevention advice. Isn't that multifactorial? It's more than one single intervention. So depending on how you interpret it or how you define multifactorial, this is also multiple interventions to reduce fall risk. This 2017 systematic review was examining, once again, more interventions on preventing falls in older adults. And they found that exercise and vision assessment and treatment, exercise plus vision assessment and treatment, plus environment assessment and modification, clinic level quality improvement, blah, 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 blah. It showed that, yes, exercise is beneficial to decrease fall risk, but we have to address the other problems that are occurring in each patient, all right? Just like the last few systematic reviews were also saying, we have to take a multidisciplinary, multifactorial approach to treat each aspect of fall risk in each patient. All right, as a physical therapist, can I perform some kind of visual acuity test when assessing balance for my patients? Yes. But I would like them to get the best care they can for vision by an optometrist or ophthalmologist. Can Draymond Green shoot a three-pointer from the three-point line if he's wide open? Absolutely. But he has Steph Curry on his team, literally the greatest three-point shooter of all time. So he's probably going to kick it his way to make the three. We got to help each other work towards the same common goal. But since exercise was found to be an effective single intervention, it is the most commonly studied fall prevention intervention. And I'm a doctor of physical therapy. I'm obviously a little bit biased towards exercise. So here's a systematic review showing that, in short, both exercises alone and exercise plus balance activities found with a high certainty of evidence to decrease fall rates and the number of falls in people experiencing one or more falls, roughly by about 25 and 15% respectively. This systematic review performed by the George Institute for Global Health, Sydney Medical School, also found strong evidence that exercise as a single intervention helps to prevent falls in older adult people living in the community. This study recommends high challenge balance activities performed at least 3 hours per week, which was found to decrease fall rates by nearly 40%. All right. They did also note that brisk walking programs were not recommended for fall prevention, more than likely because brisk walking could become a fall risk in itself, depending on your patient's level of function. So here are the author's recommendations. Following practices based off of their own systematic review and meta-analysis. So they recommended high challenge balance activities, which will be different for everyone based on their level of function. Ways to make it more difficult or easier, you can vary the base of support, provide a moving center of gravity, and or decrease upper extremity support as tolerated. They recommend that it be performed at least 3 hours per week. And you got to keep doing it. Use it or you lose it. You got to keep doing it for optimal benefits. They also recommend that strength training could be included. I personally highly recommend strength training for my older adults. At the bottom, once again, for providers to make referrals as you need to. There's that multifactorial approach coming back in, right? So after finishing all of the literature review portion, we know that the multifactorial approach is best. Here is my personal physical therapist biases. And so your pointers from a PT. A lot of people ask me, all right, Kenton, what is the best exercise to do for shoulder pain or back pain or fall risk or whatever? And I tell them, it's the one you're going to do. And it's the one you're going to do correctly, right? No intervention on earth works if you don't do it, right? And so my recommendation is that you got to fit into their lifestyle, right? Try to stand with your feet together in balance as you're brushing your teeth, or maybe try a tandem stance while washing the dishes near the kitchen counter. Okay? Something that fits into their lives so that they actually do it. Next thing is that you got to meet patients where they are, not physically, but functionally. Everyone is at different levels of fitness and function. That's okay, right? If my patient can't static stand with the normal base of support without swaying, best believe I'm going to have them practice that versus my 20-mile-a-week runner. If they can't stand in a single leg with contralateral hip flexion, absolutely, after my assessment, I find it, I'm going to make them work on it because they have to do that to perform the task that they want to do, whatever their level of function is. You just got to meet them there. Next point is to fit interventions to patients and not patients to interventions, right? Sprinting is a great way to develop lower extremity strength and power. I'm probably not going to have my 80-year-old golfer do that though, right? Which also ties back into the first bullet point. You got to find things that are appropriate for your patients to do and things that they ultimately will do. Next point, people ask me a lot about assistive devices. What do I recommend? And off the top of my head, I always tell them, I pick the least restrictive device. Sorry. Walking backwards as a tool to increase balance. I've heard of it. I have not looked into the literature on it specifically. It would work muscles in a different way, in a different order throughout the gait cycle. More joint proprioceptive feedback. But everyone's favorite answer, it does depend. If your patient can't walk forward, you would have to see how they walk backwards to improve balance. But if walking backwards is the only intervention they're willing to do, they don't want to do anything else I tell them, I'll probably have them walk backwards to practice their balance, which is more than sitting in a chair all day. So it depends on the patient. Ultimately, I would have to look a little bit more into that to see what the exact effects of that is. Back to the assistive devices, always aiming for the least restrictive device. Your front wheel walker would be on the more restrictive as it utilizes bilateral upper extremity support, which some patients do need. The least restrictive being a single point cane. But in my experience, pretty much all patients hate the idea of a single point cane. And so once again, if they're not going to use it and they're not going to use it correctly, then that itself can become a fall risk. I find better adherence and better outcomes as I recommend patients to use walking sticks or walking poles. I have read studies that improve Berg balance scores significantly just by holding onto a walking stick. Once again, it has to be used correctly and safely though, otherwise it becomes a fall risk in itself. And my last tip is that I try my best to explain to my patients that this is a lifestyle change. A lot of people come to physical therapy thinking, oh, I'll do a few exercises here and there and I'll be good. No, you have to condition your body to meet the demands of your lifestyle. So depending on what your lifestyle is, you have to prepare it for that. And just like the previous study had mentioned, you got to keep doing it. It's got to become regular practice. Therefore, it is a lifestyle change. Are there specific considerations when using a rollator walker versus front-wheeled walker? That would be dependent on your patient's function. I like the rollator walkers. It has a basket on it, primarily why I like it. But I find that a lot of patients either may act impulsively or don't use it safely enough. A lot of which I find got it from someone else. It wasn't even prescribed to them in the first place. And so now they're just running around with it to help them get around. Specific considerations, I don't have any linked cited literature for it in itself, but once again, it would be a case-to-case basis. The front wheel walker is a bit more restrictive. The PT brain in me is telling me that it's a bit more safe with the restrictiveness. You would have to assess for your patient yourself which one helps. Does it become a fall risk when they use it, or is it beneficial? Yep, the basket in the chair, that's correct. And so once again, which is the device they're going to use? Front wheel walker would be great. A lot of patients don't like it. They don't like looking at it. They don't like hearing about it. So if they ain't going to use it, hey, it's not going to work. So yeah, it's very dependent upon each patient. So recommended exercises I like to start with a lot of my elderly patients or fall risk patients. On the left-hand side here, I always start with lower extremity strengthening. Strength will go, atrophy will occur at any age, with any gender. It will happen. And a lot of times I find them, they're just weak and the muscles can't meet the demands to balance. Starting with some sit to stands, some calf raises to increase ankle plantar flexion throughout the gait cycle at push off. And as they build up that strength and endurance in the lower extremities, starting with some more balance activities. And so from easiest to hardest, going with feet together in this narrow stance, this modified tandem if they can't get completely to this tandem stance. And for me, a gold standard is always work up to this single leg stance. A lot of patients ask me, I don't stand on one foot. Why do I have to do this? Well, throughout the gait cycle, there's a whole single leg phase of gait. So if you can't support yourself unsupported on a single limb, how are you supposed to walk safely? So that's always a gold standard. Some patients don't always get there, but I tell them that's the goal we're trying to work towards. I do make sure that I tell them, do not hold on to a chair for safety. These are just what the pictures provided in the home exercise program that I use. But I always recommend patients to stand by something sturdy, whether that's a kitchen sink, a bathroom sink, counter, a heavy, sturdy table. Even a wall is better than nothing. You can't grab a wall, but it's not going to move or fall over like a chair or a walker would. So I do not recommend walkers or chairs for safety when performing your activities. And then this last one here on the bottom, increase foot clearance from the ground. If you're walking and clearing whatever object on the ground it may be, also adds anterior displacement to recreate the gait cycle. So my take home points: know your fall risk factors. Sedentary lifestyle can lead to deconditioning, weakness, other factors affecting balance and mobility. Medication, sensory and neuromuscular and psychological factors also may impair balance as well. And this previous falls are at the top. If you ask about previous falls, take a few extra seconds. Ask about near falls. A lot of times patients won't tell you things until you ask them it. So just to get the most complete picture of your patient as you can. We know that most of falls occur at home and that multifactorial interventions is the way to go, as outlined by scientific literature. And my PT biased opinions: exercise found as an effective single intervention. Try and get them to do some balance work, 3+ hours per week. 30 seconds per week is more than 0 seconds per week. So meet them where they're at. Try and get that center of gravity to move. Strength training if you can. And you got to do it. Bottom line, you got to do it. All right. So before we get into patient cases, any questions about anything we had covered?
Not a question. I just wanted to comment on Dr. Khan's question about evaluation of blood pressure control versus BP meds. And what comes to mind with that is orthostatic hypotension.
Yes.
I guess sometimes the higher you are, that's what I'm always told, right? The higher your blood pressure is, the farther you fall, right? And so if your blood pressures are not under good control and they're way too high, you have a bigger chance of falling if you drop. And so getting the blood pressure to be maintained at a lower level can actually reduce the orthostatic blood pressure drop. Yeah, and also trying to maybe address where is this orthostatic problem coming from? Is it neurogenic? Do they have Parkinsonian features and whatnot? And then, get an evaluation from neurology and, trial of metadrine and other types of things instead. So I'm just throwing that out there as some of the blood pressure issues that I've seen with falls.
Thank you for sharing that. The biggest thing, anytime I read literature or discuss literature with someone, it's always thinking, what do these numbers mean? Fortunately, through the COVID pandemic, we've got to see scientific literature be brought to light to the general public. And we know that not everyone follows scientific literature, but it also know that you have to look beyond the numbers as well, interpretation of these statistics. So thank you, deeply appreciate that.
Hey, Kenton, hey, it's Chad here. In addition to that comment about blood pressure and looking beyond the numbers, we have to, every patient is a little different, right? And we have to take each patient and assess their risk individually. that is, blood pressure goals. The blood pressure goals that, ACC, AHA put together are different for different groups of people. And so for our frail elderly, we can accept a little bit more liberal blood pressure goals. And then more certainly for frequent fallers, I mean, we can't just look at blood pressure goals as a blanket statement. We have to look at each individual patient and then decide.
Yes.
So unfortunately, we can't give you a direct answer, black and white, but it just depends. But we need to make that assessment as clinicians.
Yes. Wonderful. Absolutely. Thank you for that. All right. Cool. Awesome. All right. Well, I'm going to the patient case. So I have two patient cases for you all today. Please feel free to jump in, chime in, engage. And so the first patient case here, we have an 82-year-old female. She lives independently in a single-story home. She is independent with all her ADLs. Ambulates with a single-point cane at most when she's not carrying it. Alert-oriented ×3, no cognitive deficits, no falls in the past year. She did have a TIA several months prior, but is demonstrating no lasting effects currently from it. Current activity, she does not exercise regularly, but she enjoys being out in her yard, in her garden. She had no medications, as she told me she had no medical assessment in the last 30 years. So I was her second medical assessment in 30 years. So where do we begin? Multifactorial approach. I know that we all see the patients in different timings, before, after fall sometimes. So wherever your respective field may interact with this patient, go ahead. And where would you begin? Medication. Yes. Conciliation review. Absolutely. Who knows what other comorbidities this patient has? She said she feels fine, but always recommending a full assessment, full checkup. Home visit, especially garden. Yes. If your profession, you're given the opportunity to assess or modify home environments, we all know that's the most likely place for older adult falls to occur, which means if you have that opportunity, you are right in line to help decrease that fall statistic right away. Optometry, beautiful. All right. So the PT assessment found absolutely poor lower extremity strength, lower extremity and upper extremities, poor static balance without her assistive device in the single leg stance. She could maintain tandem balance without any upper extremity support for 30 seconds. Physical exam, absolutely. Neurological, yep. No neurological deficits was found during physical therapy exam. Timed up and go test was 8 seconds, and her 6-minute walk test was 30 seconds with that single point cane. And so the PT side of me, she looked great. Sometimes it doesn't always work out that way, but functionally she moved very well, balanced a little shoddy, and her legs were very weak. So in my realm of expertise, first thing I started with strengthening the lower extremities. And then when the legs were strong enough to perform tasks, then going into the balance, absolutely discussing home setup, making sure what she is doing and the way she's moving around at home is safe. And then all these, yes, these other referrals, physical examination, absolutely. Everything else to go get checked out. Some people have asked me about sensors and alerting systems from the studies that I found that I did not include. In hospitals, it was not found to be significantly improved with sensors, but nowadays with smart devices, basically you can yell at your phone or your Echo or home system device to call 911. So if worst case scenario, something were to happen and they were cognitively able to use verbal commands to their device, that's also a safe way to alert for help if they're living independently. Okay. Any more recommendations for this patient?
Dr. Jeff Galbraith says physical exam, especially that neurological exam.
Absolutely. Absolutely.
Sometimes you can find some hidden things like hemi neglect that nobody noticed. Yeah. And Mary says a public health nurse referral for a home visit assessment.
Yeah.
Counseling on lifestyle changes to improve
Yep.
strength and balance.
Absolutely.
So I think Sarah Tompkison does Tai Chi, right? You're a Tai Chi master.
Ooh, wonderful.
You want to comment on that? Oh, where's Sarah? Oh, I thought she was here.
Oh, that's okay.
Was on. Maybe she.
She is on. Maybe she can't. Like,
Oh, she's unmuted. She might not be connected to audio.
oh, okay. Yeah, she's texting. So, I mean, she's chatting. So she's in there. Okay.
Tai Chi is wonderful. Tai Chi
Yeah.
is wonderful. I do highly recommend.
No, we cannot hear
I do
you,
not hear
Sarah.
anything. That's right. We can bring up Tai Chi into our next patient case, actually, because that is one I did recommend Tai Chi to Tai Chi for specifically. And so the second patient case, 75-year-old male, severe Parkinson's disease, stage 4. Oh, they're wonderful. Has been adopted by CDC for fall prevention. Beautiful. Was diagnosed with Parkinson's about 25 years prior. Resting tremors in bilateral hands, bradykinesia with shuffling gait pattern. He ambulates with a quad cane. He lived with his wife in a 2-story home, only stayed on the first level, was too afraid to navigate stairs independently or with the help of his wife. He was independent with all of the ADLs, a little bit assistance with some of them, but he did have proper equipment, shower chair for home activities, things like that. Alert and oriented, slow, soft speech. He had 1 fall in the last year without injury, fortunately. Some of his comorbidities included hypertension, elevated cholesterol, previous history of depression, and he had low BMI. His activity levels, he told me, was that he enjoyed playing mahjong, and that was about it. And so with the intervention side of things, after his physical therapy assessment, is everything that we had found as results. And Tai Chi is actually one that I had spoke about. And so, Sarah, if you wanted to speak about Tai Chi, absolutely, I would love to hear it.
Can you still hear me?
I can hear you now.
Thank goodness, I'm struggling with this. So I guess what I really want to put a plug in for Tai Chi is we've seen people that haven't done any type of physical activity and have been sedentary. And for the first time, with the Tai Chi, they're learning the importance of how they should move in a slow, gentle resistance. And so it does definitely, I've been teaching at the YMCA for this special grant since February, and I've had people even tell me that they're able to visualize that before they fall, they were able to remember that they needed to keep their feet shoulder width apart and bend their knees. So there's so many other benefits to Tai Chi besides falls prevention. It's also very good for people that have arthritis. If you use the Sun style, it's a preferred higher stance as opposed to most people in Hawaii use the Yang style. And with the higher stance, there's less stress put on your joints, right, Kenton?
Interesting. I don't know the exact names for the Tai Chi styles. I have read studies, yes, and they show very good outcomes in the Parkinson patient population. That is correct.
And then there was a program started just before the pandemic. It's called A Matter of Balance, and it was a evidence-based program started in Boston, and here in Hawaii, they if you look up under the Department of Health, they have a falls consortium, I believe, right, Dr. Wen? Falls Prevention Consortium, and they've also been trying to coach train people, lay people, to consider becoming coaches for a matter of balance. That's the name of the program. But I really appreciate how you highlighted the quality of life can be negatively impacted for people that have had falls. We've seen that people get depressed, after they have a fall, and more importantly, they're afraid of falling again. So they become socially isolated because they don't want to go out of their house. And much as they love seeing the Waikini volleyball players, they're not willing to go out to risk having an injury at the stadium if they're going to fall. And it's so sad. They get depressed and withdrawn and so on. So thank you for highlighting that. Again, it's really about quality of life.
Absolutely. With this patient in particular, motivation was definitely key. I remember the look he gave me when I told him we were going to go practice stairs. And within a single session, I measured his strength. I knew what his balance looked like. I was like, you have to try it. I'd much rather you try with me safely than at home independently with your wife, who does not feel comfortable assisting you. This is what I'm here for. And so we went, took a little bit of time, educated him that more stimulus, more distraction may affect physically what your body will perform due to your condition. So gave him his pointers, and he did it with me just following by, standby assist, no contact whatsoever. His wife almost started crying, and she started smiling instead. So the depression, the change in mental status with their function absolutely has a huge part to do with it. You gotta keep doing it. Studies show, you gotta keep doing it. Awesome. Any more recommendations from our other areas of expertise? I know we're talking about vision assessment. I know we have OT. I don't know if we have speech here for this patient. Yeah, on the PT
I
side of
just
things.
want to also mention, I know we are actually short on time. We got 1 minute left, but oh yeah, so Sarah wants you to talk about assessing the environment. I just wanted you to just quick comment on music therapy for
Oh, sure. Quick comment on
go with
assessing.
the physical therapy.
A quick part on assessing environment. Obviously, you don't want clutter on the floor. I find that to be a big problem with geriatric patients, whether it's their belongings or the grandchildren's belongings. Ask your grandchildren to just move them to the side to keep it clear. Other home assessment pieces, showering, bathing equipment. I know occupational therapy does a good job at assessing, taking care of those things. I always have them show me exactly what they're talking about as best we can. I'll stack up RX pads and use little foam rollers and just recreate everything, or tell them to show me pictures of what it looks like. So to make sure, how high is your bed? How high is it relative to you when you're standing and getting out? Where's your chair? How far are you walking from point A to point B? How tall are these steps going in and out of your home? Is there a railing? Do you have upper extremity support with it? Which side is that upper extremity support on? So anything and everything that they have questions for, I'm like, I need to see it specifically for you, as every patient is different home environment, different level of functions. Should I make 2 trips to the car to take in my groceries, or grab them all in my arms? Depends on your level of function. How good are you at walking from point A to point B with an altered center of gravity and upper extremity resistance? If you can do it safely, keep doing it. You use it or you lose it. If you cannot walk safely from point A to point B without upper extremity perturbations, take your time, take the 2 trips. Maybe taking breaks in between those 2 trips if your body is winded, getting from the car into your home.
Okay, so I just wanted to just acknowledge that we are over time right now, and glad that we enjoyed the discussion. So I just want to give people a chance to, sign off if they want to, because yeah, but if, I don't know if you don't mind answering a couple questions, you can just stay on afterwards, but not very much longer, because we do need to go to other things. But thank you so much. And we do have a link for CME. Make sure you click on that and fill that out. Thank you so much, everybody. And thank you so much, Kenton and the ECHO team.
Thank you guys.
Great.
Thanks,
you.
Kenton.
Thank you.
Okay, great. Do you know if there's evidence for how much